Hello, Bacho. Welcome to the discussion of oral surgery questions of the All India Mock or the NEET GT12. The first question is identify the procedure which is designed in the picture. Now, you can all see here that this is the image of the palate. Okay, so if I have to mark here, this is the palate. Ideally, it should have been one, but you can see that there is a good big cleft there, right? The levator veli palatini, which should have been a continuous muscle, is actually split. What is the surgeon doing? He is kind of undermining the mucosa here, undermining the mucosa there, and stitching the palate, the nasal floor, the palatal mucosa in one line. Okay, so basically, this is a palatoplasty. Cleft palate surgery is also known as the palatoplasty. Now, is it alveolar bone grafting? No. Alveolar bone grafting uses bone. Here, there is no bone that we see. Is it pharyngoplasty? So, pharyngoplasty is a procedure done in the pharynx, usually for the valopharyngeal incompetence. So, no, this is not pharyngoplasty. Is it chyloplasty? Now, what is chyloplasty? Chylos means lip. So the surgery for cleft lip is known as chyloplasty. So if there had been a cleft lip, it would have been somewhere here. So this is clearly a case of palatoplasty. Very quickly, just discussing the different cleft designs. You can have a unilateral cleft of lip. So remember, a cleft of lip starts from the floor of the nose, upper lip, till the anterior part of the maxilla, which is known as the primary palate. Okay, so the primary palate, which is formed of the median nasal processes, all right, whereas the secondary palate developed from the palatine shells. So whenever there's a cleft lip, there's always a cleft of the floor of the nose, the lip up to the primary palate, up to the incisive foramen. Okay, and it is usually repaired together. Whereas the cleft of the palate, the secondary palate, can be from the back also, right? It can start because the palatine shells which fuse from left to right, they are unable to fuse. So it can be just the soft palate or the soft with the hard palate. Okay, so like that. Second question. A young girl with a history of trauma due to fall from a moving two-wheeler is brought to the emergency department. She has a nasal bleed which is controlled with pressure packs. On examination, she is found to have mobility of maxilla at the level of alveolar ridge. At this point, you should know mobility of maxilla at the level of alveolar ridge. This level. Okay, so we are kind of talking about a Lee-Fort 1 fracture. Always remember, whenever the question has a lot of facts, whenever the question has a lot of data, don't worry, it is an easy question. All right, a straight liner. Okay, who gave the Lee-Fort 1 surgery? Now that may be difficult because either you know it or you don't know it. Whereas whenever you have a lot of facts in the question, usually the question is easy because you have a lot of data. From one line or the other line, you will be able to get to the answer. All right. So coming back to the question, mobility of maxilla at Lee-Fort ridge is Lee-Fort 1 fracture. And plus that, with that, there is an anterior open bite, posterior gagging of occlusion. So that means it's an impact fracture. Okay. The fracture has caused the maxilla to go up. It has impacted into the rest of the midface. Okay. You decide to take her to OT for ORIF. You're going to remove the impaction and you're going to put some plates. Which of these instruments would be useful in her case? We have seen this is an impact fracture of maxilla at the Lee-Fort 1 level. Remember, Lee-Fort 1 fractures are very commonly impacted, right? So you have to disimpact it using some disimpaction forceps. Okay, which is the disimpaction forceps we use for maxilla? Answer is Rose maxillary forceps. Rose disimpaction forceps. Right? The Hayton-Williams forceps. The Hayton-Williams forceps is usually used for the palatal region. Okay, yes, palate is a part of maxilla. It is a part of Lee-Fort 1 fracture, but whenever there is a mid-palatal split or whenever there is a shift of maxilla left and right, you take the Hayton-Williams forceps like this and you bring it back. But if it has gone up, if it has gone impacted, you will use the Rose disimpaction forceps. Now, how do you use the Rose disimpaction forceps? The nasal part, the flat blade goes into the nasal part, whereas the curved blade comes like this and goes into the mouth, into the palate. right? So out of these options, the curved part goes inside the mouth, flat part inside the nose. Yes, this is the correct answer. Very quickly, let us look at a leaf foot 1 fracture. Leaf foot 1 fracture is a fracture of the midface at the alveolus. All right, what it gives? It gives the opportunity of the leaf foot 1 segment to go inside. See, all these bones are very paper thin, so you can just push them one inside the other. Okay, and this can happen. This kind of clinical situation can happen where the maxilla is impacted into the rest of the midface. Okay, so it has caused an anterior open bite, it has caused a posterior gagging of occlusion. In this case, there is a mid palatal split also. Okay, you can see that gap, or you can maybe see that tooth missing. Okay, so what we will use here, we will use the Rose maxillary disimpaction forceps. Remember, there is a Rose zygoma elevator also. Don't get confused. The Rose maxillary disimpaction forceps has two blades. Okay, one blade is flat, which goes into the nose like this, the flat blade. The curved blade, obviously, it has to negotiate the whole maxilla, anterior maxilla, and come to the palate. So that padded curved blade will go into the palate. Remember, Rose maxillary disimpaction forceps is a paired instrument. You cannot use just one. You cannot use just one nostril. Okay, it will create imbalanced forces. It can create worsening of fractures. You always use it in pairs. So left and right, there is no distinction. You can use either of either. Put the flat blade into the nose, put the curved blade into the mouth, stand behind the patient, rock the maxilla, bring it out, and then fix it with plates. Right? So that's how you use the Rose maxillary disimpaction forceps. The other option was the Hayton-Williams forceps. The Hayton-Williams forceps. This is what you use when you have a shifting of maxilla left or right. You hold the whole maxilla like this chimta, right? And then you can rock it left to right. Here we don't want to rock it left or right, right? We want to use it to bring it down. In that case, Rose maxillary disimpaction forceps. Hayton-Williams, whenever there is a palatal fracture or a palatal split, it kind of brings the palate together also, right? So this is the second question. Coming to this third question, an accelerated or prolonged physiological growth of bilateral mandibular condyles causing elongation and prognathism in a 23-year-old male. Now we all know that this is condylar hyperplasia. Okay, what we need to know is the Wold-Ford classification. Okay, these days a lot of questions are coming on condylar hyperplasia, and what is important is the Wold-Ford classification. Let us quickly look at the Wold-Ford classification. Condylar hyperplasia type 1. It is a physiological enlargement. Okay, there is no disease, there is no tumor, there is no abnormality. It's just physiology. The last growth spurt, in the pubertal growth spurt, or even beyond that, the patient is growing the condyles too rapidly and too much in proportion to the rest of the face. This is the class 3 or a prognathic profile, right? The difference between type 1A and type 1B is type 1A is bilateral and type 1B is unilateral. That's the only difference. Alright, so what is the Wold-Ford classification of condylar hyperplasia? There are 4 types. Type 1, type 2, type 3 and type 4. Alright, type 1 has a type 1A and type 1B. Type 1A is bilateral mandibular condylar enlargement. Type 1B is a unilateral. Right? And type 1, what is type 1? Type 1 is basically physiological growth. Right? Coming to type 2. Now type 2 is typically a condylar hyperplasia caused due to osteochondroma. Now you will ask me, ma'am, why osteochondroma? There are so many tumors that can happen in the condyle, in the bone, in the cartilage, right? The most common tumor in the mandibular condylar region is osteochondroma. That is why it has been classified separately. Okay, so osteochondroma, again, let us look at it. It is also of A and B, type 2A and type 2B. Now, type 2A is a vertical elongation of face. Okay, but vertical vector of growth with no horizontal component. Okay, I will explain it to you with a diagram also. Whereas type 2B is a vertical elongation of face, excessive vertical vector, but there is an additional horizontal exophytic growth of the condyle, and this has been asked as an image based question previously in exam. All right, so why vertical is because, see, if this is the mandibular condyle, right? Imagine this is a patient's mandible, condyle and coronoid. Let me draw it properly. So if this is the mandibular condyle, right? If there is a tumor here in the cartilage, okay, obviously the tumor will grow like this because the space is within the joint. Everywhere else it's a closed structure, right? So this is how an osteochondroma will look. But this will be osteochondroma type A. So this will be condylar hyperplasia type 2A. Sometimes the osteochondroma, apart from this vertical vector, has a horizontal exophytic growth also. So it grows towards the lateral pterygoid muscle and gives this horizontal exophytic. Exophytic means like growth. Okay, and it is usually vertical. Sometimes, apart from that vertical growth, there is a horizontal growth factor also, and that classifies it into a type 2B condylar hyperplasia. Okay, so this is type 1 and type 2. Only this is important for you in exam. Okay, what is type 3? Type 3 is any other benign tumor. Okay, so I will write it here. Type 3 is condylar hyperplasia due to any other benign tumor, which is very, very rare. Okay, and type 4 is due to any malignant tumor, right? So please understand, condylar hyperplasia type 1 is without tumor. It is a physiological growth. There is no tumor, there is no pathology, right? Whereas type 2, 3, 4 are due to a tumor. Okay, type 2 is due to osteochondroma, type 2A due to only vertical growth, type 2B due to horizontal growth also. Type 3 is due to any other benign tumor, type 4 is any other malignant tumor. Now obviously tumors are not a bilaterally symmetrical thing, right? So type 2, type 3 and type 4 are usually always unilateral. Okay, they are always unilateral. So tumor होगा तो obviously कहीं एक जगह पे होगा, right? It will be in some one place. So type 2A unilateral, type 2B also unilateral, type 3, type 4 also unilateral. Okay, whereas only bilateral is present in type 1 because it's physiological growth and it can happen symmetrically on both sides. Okay, so the only bilateral case will be type 1A. Sorry. Type 1A. This will be the only bilateral presentation of condylar hyperplasia on radiograph. So whenever you see a patient who has bilaterally enlarged condyles, you should be happy, oh, it's physiological. Because only abnormalities can be unilateral. Okay, so this is condylar hyperplasia and this is the Wolford's classification. You should all know it. Okay. Okay, next question. Intranasal antrostomy is commonly done through. So when it is not mentioned whether it is adult or pediatric, please consider it to be adult and mark the inferior meatus. Okay, so intranasal antrostomy is done through the inferior meatus in adults, and in young children where the sinus is not yet pneumatized, it is done through the middle meatus in children. Why do we do that? Because the level of the sinus is till the middle meatus in children, whereas it has gone much below till the inferior meatus and even beyond the inferior meatus sometimes in adults. Okay, so what is antrostomy? Antrostomy is basically a stoma. What is stoma? Stoma means mouth. Stoma means mouth or opening. So antrum, what is antrum? Antrum is maxillary sinus. Antrum of Highmore, remember? So antrum is the maxillary sinus. So antrostomy, creating an opening or creating a stoma in the antrum. Why do we do that? Suppose I've done any surgery in the maxilla, okay, which is involving. So maxilla is what? It's a paper thin bone here and it is filled with air. The sinuses are filled with air. Suppose there is a tumor. Suppose there's a tumor that I have done here. Okay, there's a tumor and I have done the tumor resection. Okay, now what will happen? The whole surgery, the whole sinus will be filled with surgical fluid. Okay, in the post-operative period also, there will be drainage. So whenever we do any surgery, post-operatively there is edema, there is inflammation. Okay, there is exudative and so many kinds of fluids because of the surgery also that will collect into the sinus. Now, any fluid which is there in the body abnormally will cause infection. I don't want, after I have resected my tumor, after I have resected this tumor, I don't want this transudative or exudative or any kind of blood, anything I don't want in the sinus. I want it to drain, because if it is collected there, it will cause infection. Okay, that is true for every surgery. If I've done a TMJ ankylosis, I will put a drain so that whatever the post-operative fluid or post-operative bleeding is happening, it should drain slowly and it should stop. Similarly, if I've done a surgery in the maxilla, I want the sinus to be clear after surgery. For that, what do? I will do an antrostomy. I will put a fracture. I will put an intentional fracture in the inferior meatus. We all know this is the inferior, middle, and superior turbinates. Okay, there are three turbinates in the nose: the superior turbinate, the middle turbinate, both of them are part of the ethmoid bone, and the inferior turbinate, which is a separate bone. Below the inferior turbinate, I will do a fracture and I will connect the sinus to the nose. I can put a drain, I can put a gauze piece so that whatever collection is there in the sinus, it will drain out. Okay, why do I do that typically? Because the natural opening, if the sinus is much high, it is much above. You can see this is the natural opening of the sinus, which is in the middle meatus region. It is much high. If I expect it to drain from there, no, it is not going to drain. Physiologically, yes, little bit fluid, because of the ciliary action of the lining of the epithelium, it will drain. But so much fluid, it will never drain. It will cause infection. So I want it to drain through a gravity mediated channel, through a dependent channel. So what I will do, at the level of the sinus, so this is the sinus, it has pneumatized much below the middle meatus. So we'll put a fracture here and we'll put a drain. What will happen to the fracture? Nothing will happen. Don't worry about the fracture. Okay. Now in children, you know that the sinuses are not so much pneumatized. They are still probably at, they're still probably at this level. They have not, with age, the sinuses pneumatize. They increase downwards. In children, maybe it is still up. It is still at that level. So why do I unnecessarily want to puncture the inferior meatus? I will just give an enlarged opening into the middle meatus and that is it. Alright, so that is the reason why we give it slightly higher in children through the middle meatus, depending on the level of the sinus, depending on the pneumatization of the sinus. And in the elderly, in the old people, where the sinuses have pneumatized much below the inferior meatus, the superior meatus, we fracture the inferior meatus for antrostomy. Okay, I hope this concept is clear. Anything, if it is not clear, if you want me to come back to it, you have the Telegram group. You can ask me there and I'll be happy to explain it again. Okay, the incision shown in the image below is an indirect approach to management of which fracture? Now, we all know that this is the Gillies temporal approach. The Gillies temporal approach, the incision around 1 to 1.5 centimeter incision is given in the temporal region. It is done at the bifurcation of the superior temporal artery, the ST max of superficial temporal artery, the anterior and the posterior division of the superficial temporal artery. Between that, at a 45-degree angle to the pinna of the ear, we give an incision, which is the Gillies temporal approach. What do? You dissect till you reach a plane between the muscle and the fascia. So temporal muscle and the temporal fascia. Between that, you will slide your instrument. It can be the Bristow's elevator. It can be the Rose Zygoma elevator. These two instruments you will slide, and what you will do? You will make your instrument go from here until the undersurface of your fractured zygomatic arch or zygoma. Okay, you can see here there is a fracture. It can be one fracture, two fractures, whatever it is. You will go under the fracture and you will use your instrument to raise the fractured bone up. Okay, so is it giving a direct incision on the fracture? Is it exposing the fracture line directly? No, it is not. That is why it's a closed reduction. So what will be the answer? It's for the infraorbital rim and orbital floor fracture? No. It's for the zygomatic complex fractures? Yes. It's for the zygoma and the arch. Is it for the lateral wall of orbit and FZ suture? No. It's right here. Why do I need to give that incision? I can give a small incision on the eyebrow. So it's not for this. Is it for the maxillary fracture? No. For the maxilla, I can go intraorally. I don't want to go from the temporal region. So the correct answer is zygomatic complex fracture. Okay, so these are the two instruments. This is the incision, like I said, between the two branches of the superficial temporal artery, a 45 degrees incision. You put your Bristow's elevator. Now these are the two elevators. This is the rhozygoma elevator. This is the Bristow's elevator. What is the difference? It is a single bladed instrument, Bristow's elevator. So the fulcrum will lie on the temporal bone and you will never be able to judge how deep you are going. Whereas the rhozygoma elevator, it's a double bladed instrument. The outer blade is exactly at the same length as the inner blade. So you can check when you put the inner blade, you can close the outer blade and you can check at what depth you have reached. It's more predictable, more precise, right? And the fulcrum is on the instrument. When you pull the fracture up, when you pull the bone up, you don't have to depend on the temporal bone. You don't have to put a fulcrum there. You can just use the blade of the instrument and pull it up. Okay, so it's a better instrument, the rhozygoma elevator. Okay, coming to question number 6. Which of these are advantages of using titanium mesh over autologous bone for orbital floor reconstruction except? Now, which is not an advantage or which is a disadvantage? That is asked. Okay. Now, first option is better adaptability. Definitely it is an advantage because see, autologous bones means most commonly we use the calvareal bone. The calvareal bone. Okay, I will take some part of parietal bone because I have to reconstruct the orbital floor. What is the shape of the orbital floor? It's a flat bone. So I need to take a flat bone from somewhere to reconstruct the orbital floor. Where is the flat bone? Somewhere on the skull. So I will take a skull bone. It is flat, but can I change its shape? No, it's very, very difficult. Whereas if I take a titanium mesh, it's basically a metal mesh made of titanium. Why titanium? Because it is bio-inert. It will not react. I can't use iron or cobalt chromium there. I have to use an inert material. Gold, silver, titanium. Gold, silver, very expensive. Titanium, relatively not so expensive. So I will take a titanium mesh and I can change the shape. So somebody's orbit, maybe it is fractured less in the wall, more, less in the floor, more in the orbital medial wall. So I can shift that. Alright, I can curve it. I can give it a shape. So the adaptability to the original bone is much better. Right? Second, size of the mesh can be chosen as per the defect. Yes, you can do that. You can cut. Suppose I don't want a big, suppose the fracture is small. I don't want such a big mesh. I can cut just this much part. Okay, I'm going to use only this much. Yes, I can do that with a graft also, but I can do that very easily with a mesh also. So that's definitely an advantage. Good results? Yes, very good results. Donor side morbidity is not there. Results are good. So that's also an advantage. Long run to heal at the donor side. Obviously, this is not a problem because there is no donor site. Titanium mesh I am purchasing from the market. Where is the donor site? The donor site is in the autogenous bone. Okay, so that's a disadvantage of the autologous bone, not of the titanium mesh, right? So this is not an advantage. Okay. A patient has been recently prescribed oral hydrocortisone. What is oral hydrocortisone? It is a steroid for an autoimmune condition affecting her adrenal glands. Now, which autoimmune condition which will affect the adrenal glands? It is adrenal insufficiency. It is adrenal crisis, also known as Addison's disease. Okay, she's taking the drugs since last 3 months, but has failed to take them today. Okay, she comes to you for tooth extraction, and soon after LA becomes unresponsive. Okay, following the collapse, she was given oxygen by mask, vitals were monitored, and 100 mg steroid was additionally given. What is the direct treatment directed towards? Now, see, this is very, very rare. Okay, I've purposefully taken this question in the GT to let you know that this situation is very rare. You will have very few patients of adrenal insufficiency in your practice. And those who are the patients, they will know that I have this big problem. I cannot move around for any procedure, for any surgery without steroids. And this is where history taking becomes very important. You have to know the history of the patient. So, only in very limited conditions like an adrenal insufficiency, you need to give the patient the double dose, the double or the additional dose of steroids that the patient is taking. Okay, so suppose a patient is taking, say, 20 mg Vizolon daily. Okay, suppose this is the daily dose. So additionally, you will give some more drug so that his daily needs are taken care of and the additional needs of surgery are also taken care of. Okay, what are the needs? The needs are stress, management of stress. All right, our body undergoes lots of physical stresses throughout the day. Okay, what takes care of those stresses? The steroids take care of the stresses. Steroids are made by the adrenal gland, the adrenal cortex and adrenal medulla, mostly the adrenal cortical steroids. Okay, now if somebody has a problem with the adrenal gland, his or her body is not able to make the steroids, what you will do? You will give additional steroids from outside. Okay, how much steroid you will give? You will give enough steroids to take care of their daily needs, right? But if there is an additional need, like an illness, like fever, like surgery, like trauma, there is extra need of the body. In such cases, you need to top up the steroid. You need to give extra, especially if you are doing an elective surgery like a tooth extraction or any dental procedure. You can plan it. So only in such cases you need to give additional dose of steroid to take care of those extra stresses that come with surgery. Okay, other than that, there are very limited indications of doubling up steroid. Usually this will not happen very routinely. Okay, so answer is acute adrenal insufficiency. Next question. Which of these drugs can be injected systemically to control bleeding at the extraction site? The answer is tranexamic acid. Okay. Now, when we talk about hemostasis, okay, when we talk about controlling the bleed, there are two types of agents which we can use. Okay. We can use topical agents. That means wherever there is bleeding, put something on that. Okay. We call it styptics. We call them styptics, right? Or there can be systemic agents. You give something in the system, in the circulation, to improve the clotting ability of the whole body, right? So these are the drugs which are given IV. All right, styptics are always given locally. What are the examples? You give pressure. Pressure is not really a styptic, but with that pressure gauze, you can give adrenaline, which is not advisable because it will cause rebound bleeding. Or you can give certain other drugs like, this tannic acid and all these astringents, tannic acid and zinc chloride and all these astringents which used to be used in the last previous times. Recent ones, there is oxidized cellulose, okay, which is known as oxycell. There is a collagen or a gelatin foam, which is known as gel foam. Okay, there is a Surgicel, which is very expensive. So these are all brands. Basically, these are thrombin soaked gauze or cellulose gauze, collagen foam. So these are agents which will rapidify the process of blood clotting. All right, and they will be there as a barrier to bleeding. So these are all topical agents. Okay, whereas some agents are systemic. You can give them IV. Okay, like tranexamic acid, like ethamsilate, like aminocaproic acid. These are all systemic agents. Okay, so suppose I'm doing a surgery, I'm doing a leaf foot 1 surgery, and I'm expecting that there will be a lot of blood loss, there will be a lot of bleeding because I'm cutting the whole maxilla, separating it from the soft tissues. Definitely it's going to bleed a lot. So I'm anticipating there will be a lot of bleed. I can't put the styptic in any one place, it is multiple places. What I will do? I will ask the anesthetist, please give one IV tranexamic acid, 1 ampule to the patient at the beginning of surgery only. Alright, so this is a systemic agent. Now the beauty about tranexamic acid is, please understand this, tranexamic acid is current favorite of the examiners. Please understand, tranexamic acid can be used both topically and systemically. So you can break the ampule of the tranexamic acid, you can empty it on a gauze, and you can put it with pressure on the site of extraction or on the site of bleed. Okay, so you can do that also. It is an antifibrinolytic agent. Antifibrinolytic agent. What does it mean? It will prevent fibrinolysis. It will prevent the lysis of the fibrin clot that is formed at the site. Okay, so whatever is the reason of loss of clot, or what is the reason of bleeding, it will prevent that. Okay, so it's an antifibrinolytic agent. You can empty it in a gauze and put it at the site. So it can be used topically also, unlike so many other things, right? And you can load it in a syringe and give the patient some IV tranexamic acid also. Of course, you have to know the medical history of the patient. You should not have a clotting disorder. Otherwise, you will be inducing clotting. So medical history is very important. But otherwise, this is one drug, tranexamic acid, popularly in the name of Tranexa or Texid. These are brand names in which it is available. Okay, so you can purchase that ampule, use it topically. If it is not working topically, give it IV. If it's a lot of bleed. Okay, so this is one favorite agent of the examiners these days. Please remember it. Okay, next question. How much epinephrine can be administered to a patient with angina pectoris? This is standard line picked up from Malamed. Answer is 0.04. There is no concept that I need to teach you. Simple fact, angina 0.04 mg adrenaline is the maximum you can give when you are giving LA. Okay, so your LA, you should calculate, it should not be more than 0.04 milligrams. Alright. Calculate the Pedersen difficulty score in the image below. Now we all know how to calculate. First thing is we will see the angulation of the tooth. It is a mesioangular tooth, right? So I will give it a score of 1. Second, I will check the occlusal level. The highest portion of the tooth, if it is at or above the occlusal level, I will give a score of 1. No, it is not at the occlusal level. The highest portion of the tooth, if it is at or above the CEJ, I will give it a score of 2. Yes, it is above the CEJ of the teeth. Right? So it is a score of 2. Okay, so occlusal level, the score will be 2. Okay. If the tooth would have been somewhere like this, the highest level is below the CEJ, then I would have given it a score of 3. Okay, so here it's a score of 2. Third thing, the ramus relationship. Whether the whole tooth is in the ramus, whether the whole tooth is out of ramus, or whether part of it is. Okay, so if I see this is a very good line which is placed there. There is this much space. Okay, whereas the mesiodistal width of the tooth is this much. Okay, so it is there. The space for the tooth to come out is there, but it is not enough. I can't take the whole tooth out. I will need to divide my tooth maybe like this, right? Take one part before and take the other part later. Okay, I will obviously not divide it like this. I will divide it like this. Otherwise, it will be a blockage. I will divide it like this. Take this out first and then take this tooth out. So yes, there is space between the ascending ramus, and the second molar. I have some space. All right, I have some space there. Okay, if the space would have been enough, okay, equal to this and this, I would have given it a score of 1. If the space would have been absolutely, so suppose the ramus started from here only. Suppose the ascending ramus was like this. So the whole tooth, this whole tooth is inside the ramus. There is no space. Then I would have given it a score of 3. Absolutely inside the ramus. But this is not the case. Alright, a lot of you confuse over this thing. That is why I am clarifying it for slightly longer. It is not the case. The ramus has given it some space. But it is this is the amount of space available. This is the space available. But it is not equal to the mesiodistal width of the tooth. It is less. So I will give it a score of 2. Neither absolute blockade, score of 3. Neither absolute space, score of 1. Something in between, score of 2. And this is how you will calculate in the exam. Okay, so third thing is the ramus relationship, which is 2. So there is a total score of 5. And your answer becomes B. Alright, so this is how you calculate the Pedersen difficulty score. Another one of the favorite questions of examiners. Please don't make mistake. And the options that they will give is 4, 5, 6 and 7. So you have to be really precise, okay, and calculate accordingly. Okay, next question. 5-year-old boy was operated for TMJ ankylosis using costochondral graft. Okay, 5-year-old boy, growing child, definitely you have to use a growing graft. What are the growing grafts? Costochondral graft or distraction osteogenesis. These are the only two options in a growing child. as per the Kaban's protocol. 3 years later, how much later? 3 years later. Enough time. Okay. He comes to a deviation of now in mm, deviating towards a non-operated side. Now, what is the cause? Definitely the cause is graft overgrowth. Okay. Understand this very nicely. This is a normal mandible. Okay. With normal condyles. Okay. This is the glenoid fossa. And this is the temporomandibular joint made by the condyle and the temporal bone, right? Now, what happens in ankylosis? Ankylosis may there is a bleeding into the joint and the condyle is gone and it is all converted into a big chunk of bone. Okay, there is no real condyle. It is all converted into a big piece of bone like this. Okay. Plus the growth. Normally, this condyle in a 5-year-old child, this condyle will be growing, right? This condyle will be growing. So, what I have lost? I have lost a bone, I have lost a joint, and I have lost a growth potential. I have lost an area where there is growth. So, there is asymmetric growth, there is unilateral shifting of mandible, and all of those things. What I will do? First, I will do a gap arthroplasty. I will create a gap. I will take a saw or I will take a burr. I will create a gap like this. I will create another cut like this, right? And I will remove all this ankylotic chunk, all this ankylotic mass. So this will be gone in the surgery, which is known as gap arthroplasty, right? Like this. So it will be, I will have a new bone which is in the shape of this. What I've created a gap. Now, can I leave it like this in a child? Can I leave this like that in an adult? In an adult, it is still okay because there will be static position symmetry. He is not growing anymore, but a child is growing. Okay, this side will grow and this side will not grow, which is what is bad. So I will give him a growing graft. Okay, I will give him a costochondral graft. So I will give a long piece of rib. On the top of it, there will be cartilage. There will be the costal cartilage, which is a hyaline cartilage, which is a growing cartilage. I will fix this with some screws on the residual ramus, right? So I have reconstructed the joint. Okay, I will be lining the joint with the temporalis fascia, and this is what I have. Okay, now what will happen? Just like this area is growing, this area will also grow. Okay, so this is the beauty of costochondral graft. But what is the problem? The problem is that the growth is unpredictable. If the child is lucky, the growth will be same. If the child is not so lucky, it will undergrow, or more commonly, it will overgrow. Sometimes it will overgrow. Alright. So what will happen? If this side is overgrowing, growing longer and longer as compared to the other side, in long term, it will not happen over 3 months or 4 months. It will take time, 3 to 4 months, 6 months. So it will take for the graft to adapt there in the new situation, right? So if the exam, the question is instead of 3 years, if the question is 3 months, please don't think it is an overgrowth. Consider it to be a facial palsy. Okay. But if it is 3 years, facial palsy resolves within few weeks of surgery. It will not stay till 3 years. All right. So after 3 years, what can happen? It can overgrow. So what will happen? The chin will deviate to the non-operated side, which is the question. 9 mm of deviation to the non-operated side. Why? Because the operated side is overgrowing. So time is very important. You will have two kinds of questions. One set of question will give you very less time, very short time. So the answer will be 3 weeks or 4 months. Alright. In that such small time, CCG overgrowth is not going to happen. In such small time, what can happen? There can be re-ankylosis. So the child is not doing physiotherapy properly, is not doing mouth opening exercises, re-ankylosis. Okay. Or there is a residual facial nerve palsy. If the surgeon is not careful, he has injured the facial nerve permanently, then there will be a facial nerve palsy. So this will be seen in a short time. Okay, if the patient stops doing physiotherapy from the next day, in 5 days there will be closure of mouth. All right, so immediately you have to start. Like if you're using CCG, within 7 to 10 days you have to start. So that's a rule. Okay, within few days or few weeks or few months, these are the usual complications. All right, but in long term, what is the long term? 3 years, it's long term. What is the long term complication of CCG? Overgrowth. So please pay attention to the duration, right, and the symptoms. So deviation towards the side of non-operated side. These are very important things. It is pointing clearly towards overgrowth, and it will never happen within few weeks or few months. It will happen over years. Okay, so this is question number 11. Coming to 12th question, in a case of bilateral ankylosis of a child, which is the biggest concern. Okay, so bilateral growing child, my biggest concern is airway, right? Because what happens is, when everything else is growing, but my mandible is not growing in a child, right? It will cause an obstruction to the upper airway. It will be an obstruction to the upper airway. And when the child is sleeping, when the muscles of the tongue and everything is relaxed, it will fall back and it will cause a blockade in my upper airway, something which is known as obstructive sleep apnea. Okay, whenever we are discussed in the classes, we have talked about it in detail, and that's my biggest concern. TMJ ankylosis is my secondary concern now. First, I have to protect the airway of the child, whether he will be able to breathe or not. So, my first treatment will be aimed at correcting the airway. How will I correct the airway? Using body distraction of the mandible. Using body distraction of the mandible, I will bring the mandible forward. First, I will open the airway. Then, either along with it or later on, depending on the protocol, I will do the ankylosis surgery. So, suppose if I do ankylosis surgery in a child whose mandible is back, whose mandible is receded, and when that child opens the mouth, so you can see here, when I open my mouth, the mandible is going even further backwards, right? The mandible is going even back. And already the airway is blocked. If you open the mouth, the mandible goes back, the airway is shattered. Plus, because of the surgical edema, the airway is absolutely blocked. So, you have opened the patient's mouth, but he's not able to breathe. So, first concern will be airway. Now, there are a lot of protocols. There is, depending on the AHI of the patient, depending on the apnea hypopnea index, I will decide whether I will do my ankylosis surgery along with distraction of the mandible, or I will do it later on. So there is a protocol, it's there in your notes. You can go back to it. That protocol based questions may not be asked in NEET. They are more of an I&I thing. But just understand that with ankylosis, very important concern is airway. Alright. So you can see here also, I have very nicely put two images. First is a normal airway. Okay, what is the airway? You can see this black shadow coming from the nasopharynx. Okay, this is the oropharynx, laryngopharynx, epiglottis. This nice black shadow which you can see is a normal airway. And versus compared to a child who has TMJ ankylosis. So you can see this airway, it's still okay. Oropharyngeal airway is still okay. And as he comes here, you can see how narrow the airway is. This is when the patient is straight, he's standing or he's erect. As soon as this patient lies down, the tongue which is there falls back. The soft tissues of the chin, which is because there is no menton of the patient, the chin is so back, these soft tissues are relaxed. And whatever airway is there, it will collapse. Alright, so what I will do? I will first take my mandible from here to here. I will pull my mandible forward. When I pull the mandible forward, all these soft tissues which are here, they will also be pulled forward. And drastically, my airway is going to open up. Okay. So the first concern in ankylosis, especially a bilateral ankylosis in a child, see, adult has already grown. Adult ankylosis is not much of an issue. The person has already grown, the airway is open. Now he is not growing. But a child is still growing. Airway is still forming. So, child airway is very big concern. Alright. Okay, next question, relatively easy one. What is bronch? Bronch is a disease and osteonecrosis of jaw which was seen due to bisphosphonates. Bisphosphonates. What are bisphosphonates? Bisphosphonates are broadly in the category of anti-resorptive agents. Anti-resorptive agents or drugs. There are so many others. There is raloxifene, there is monoclonal antibodies. What they do is basically they go and bind to the osteoclast. Very important fact, they will go and bind to the osteoclast. So what will happen? They will prevent the resorption of bone. Where are they used? They are used in conditions like osteoporosis, or they are used in conditions of bone metastasis. Whenever there is a cancer which is causing bony metastasis, very commonly breast cancer, it will cause bony mets. So you don't want those metastatic tumors to resorb the bone. So you will give anti-resorptive agents, and very common is bisphosphonates. So what it will do? It will bind to the osteoclast. It will prevent osteoclastic activity. What is the advantage? Bone resorption will not happen. Osteoporosis will be corrected. Metastasis will be corrected. What is the disadvantage? Osteoclasts don't just resorb bone in pathology. They resorb bone in normal physiology also. They help in bone remodeling, which is a very important role of osteoclast. So, whatever their blood vessels are there in the bone, what will happen now? Osteoblast has become the king. Osteoblast, bone forming cell. Osteoclast, bone resorbing cell. Now, osteoclast has stopped its function. Now, what will happen? Osteoblast is the king. He will keep depositing bone everywhere bone. So, blood vessels choked up, filled with bone. So, healing ability of the bone is gone down. The healing ability of the bone becomes weak, and it causes, whenever there is a trauma to that bone, what will help in healing? The blood will help in healing. But in this bone, there is no blood because there is excessive bone everywhere. It will cause a osteonecrosis of jaw. Necrosis, when there is ischemia, when there is lack of oxygen, because there is no blood, no oxygen. So osteonecrosis of jaw. And when it happens due to bisphosphonates, it is called bronch. Bisphosphonate related osteonecrosis of jaw. Okay. The other term which came up was Araonj, Araonj, anti-resorptive agent related osteonecrosis of jaw, or Meronj, medicine related osteonecrosis of jaw. Broadly, these are the same things. These are the anti-resorptive drugs which are prescribed to the patient for one of the indications, and it has caused ischemia in the bone. And in such bone, whenever there is a trauma, it causes necrosis. It is more common in the mandible, so that is why we call it of the jaw. Okay, so answer is B. Bromine associated osteonecrosis, no. Osteonecrosis due to bisphosphonates, yes. Brown necrotizing jaw, no. Bromhexidine, no. Answer is B. Coming to the next question, what is given for prevention of oxygen seizures from HBO therapy? Now again, in such cases, we just discussed about bronch, we discussed about chronic osteomyelitis. In such cases, whenever the oxygen in the tissues is less, okay, we give extra oxygen through a therapy. All right, any wound which is a non-healing wound, okay, like a diabetic foot, a diabetic patient whose foot is not healing, a diabetic foot, or an osteonecrosis which is not healing, or an osteomyelitic, chronic osteomyelitis which is not healing. Why is it not healing? Because there is no blood. When there is no blood, there is no oxygen, and you need it for healing. So what we do, we put the patient in a chamber which is known as a hyperbaric oxygen therapy chamber, and we give pressurized oxygen कि अगर ब्लड से नहीं जा रहा है तो कहीं से तो घुस घुस के टिश्यू में ऑक्सीजन घुसना चाहिए. So the tissue level of oxygen rises, it causes angioneogenesis, new blood vessel formation, and it helps in healing of wound. So we use HBO therapy in any chronic non-healing wound. Okay, so what happens is, see, excess of anything is bad. All right, so what it does is increases the oxygen level in the tissue, but along with that there is oxygen toxicity also. Okay, there is oxidative injury. There is oxidative injury because it is not just the wounded tissue, it will go in every tissue, right? And every tissue doesn't need it. So there will be oxidative injury. What do you give to prevent oxidative injury? You will give antioxidants. What are the antioxidant vitamins? A, C, E. Right? Remember, we read in biochemistry, the antioxidants are A, C, E. Out of that, vitamin E or tocopherol. This is what we make the patient. These are very cute green colored capsules. You make the patient eat that vitamin E regularly whenever he is undergoing the HBO therapy. What vitamin E or tocopherols will do? They will prevent the oxidative injury which is happening to cells during HBO therapy. So it is compulsory. Okay. Oxygen seizures can also happen because of this excessive oxygen. So prevention of that is give regular vitamin E to the patient. Okay. Next question, the last question of our oral surgery section. Which of these drugs is a must in the management of dry socket? Now we have discussed this multiple times. The only problem in dry socket is that the socket is empty. There is no infection. Okay, there is no pus. It is just that it is dry. Ideally, it should be covered with blood. Okay, ideally it should be covered with blood. When it is covered with blood, two things happen. First thing is these bone nerve endings. Okay, so bone is covered with periosteum, and periosteum is very, very tender. So these bone nerve fibers which are there in the bone, these nerve fibers are mechanically covered with a blood clot. So that's the first advantage. Second advantage, now the healing will happen over the clot. The epithelium of the adjacent gingiva, the epithelium will grow like this, and it will close it. So healing is faster, and these bare nerve bore endings, they are exposed. Now when there is a dry socket, what happens is this clot is gone. Now this blood clot is lost. Okay, for whatever reason, the Burns hypothesis says that there is some fibrinolytic activity due to bacteria, and this blood clot is lost. Now what happens is these nerve endings of the bone, they are not covered. So what is the symptom to the patient? Only one symptom, pain. Only one management, pain control. How do you do pain control? With analgesics. That's the only drug you need to prescribe. Is there pus? There is no pus. So why do you need to give antibiotic? Is there some inflammation? No antihistaminics, no antacids. Only analgesics is what you need to prescribe. Plus, we give some topical obtundant dressing. What do we do? If the clot is not there, now we will give some dressing. Zinc oxide eugenol or only eugenol or some butamben based paste. So we will give some dressing so that these nerve endings which are exposed, they should be covered. But obviously the dressing will come out. So you need to give it every day or every 2 days to cover the free nerve endings. Okay. Now how will the healing happen? Will the healing happen over the dressing? No. Now the healing will happen like this. Now the epithelium will grow into the socket. Instead of growing over the socket, it will grow into the socket. And when that happens, then the pain will stop. Till that time, it will take 7, 10, 15 days, depending on the size of the defect. It will take time. Till that time, you have to wait. You can't do anything. Curettage, imagine you have a wound in your hand and you are scraping it with a curette. Will you do that? Of course not. Similarly, there is a wound, there is exposed nerve endings in the socket. Will you take a spoon excavator and curette it? It will cause so much pain. And what is the use? There is no use. You will never use curettage. Never ever do curettage in a dry socket. Just irrigate. So whatever food particles is there, all the food particles will come out. Put an obtundant dressing so that these nerve fibers are covered properly, and give the patient painkiller. That is it. Yes, with painkiller, you might need to give some antacids, but antacid is not a primary management. That's just a supportive drug, because a lot of analgesics, lots of NSAIDs can cause gastritis. So as a complementary drug, you may give some PPIs. You may give some pantoprazole or ranitidine or something like that. Right? But the primary treatment is pain control, which is with analgesics. That's it. Alright, so dry socket is another favorite of the examiners. I hope I have covered most of the important topics for NEET. I wish you all the best. Do well.